This video is a part of the ASRA Resident and Fellow Committee video interview series on recent fellowship graduates. Today, I'm interviewing Dr. Brenden Moore, a recent regional and acute pain fellowship graduate from the Medical University of South Carolina. Dr. Moore, you can go and introduce yourself, including your fellowship institution and what you've been up to since graduating.
Yeah, awesome. Thank you so much, Chichi. So my name is Brenden Moore. I am currently anesthesia faculty on the Regional and Pain Service at the Medical University of South Carolina. I did my residency there at the Medical University of South Carolina, and then went immediately into my fellowship in Regional and Pain Medicine. I graduated in, I guess, July 1st of this year, and have been spending the last 5 months or so serving as an attending on the regional team there. And just really enjoying spending time teaching the residents and our current fellow, and just trying to give some of the stuff I've learned over the last 5 years back to the younger residents, and really enjoying it.
Nice. So, what made you decide to pursue a fellowship in regional anesthesia?
So I was always interested in academic medicine. So from early on in residency, working with medical students, I realized that I really enjoyed the teaching aspect of it. And so I wanted to stay in an academic institute. And I feel part of that is you have to be subspecialized in something. While it's great to be good at anesthesia, I think to really teach and be effective, you should really be an expert in a certain field. And so I was interested early on in a fellowship. And after kind of going through a little bit of everything, what I really liked about regional is how diverse and how flexible you are as a regional anesthesiologist. So I always liked things like cardiac anesthesia, but I felt like that would almost pigeonhole me into doing one thing. And with a fellowship in regional, not only do I have expertise in nerve blocks and a lot of the cases that go with that, I still also get to do a vast majority of other cases, including neuro. I do transplant. I do lots of stuff outside of just orthopedics. So I think it gave me that opportunity to be a little bit flexible.
Nice. And so, can you kind of describe what a day in the life for you was like when you were a regional fellow?
Yeah, so in my fellowship at MUSC, when I did the fellowship, it was a non-ACGME fellowship. So I kind of spent 2 weeks of a month as a fellow and 2 weeks as an attending. So it was a little bit of a transition year. But as a fellow, my day to day was is pretty straightforward and pretty set in stone. And so I would get to holding a little bit before the attending, probably 6:15 in the morning, meet up with our residents on our regional team, and start setting up for nerve blocks. And so obviously in the regional world, first starts are kind of the big busy part of the day. And so we'd kind of spend the first hour of the day just cranking out our first start nerve blocks. We have a very busy regional service, the Medical University of South Carolina. We do around 10,000 nerve blocks a year. So most days we have 6 to 7 first start nerve blocks to get done in like a 45-minute period. So
Wow.
kind of cranking those out early. After we get through first starts, the day would kind of slow down. A lot of teaching at that point. So as the fellow, my job would be to kind of get with the residents and go over a learning topic of the day. So whether that be upper extremity blocks, adjuncts to regional anesthesia, things like that, spending some time teaching them. At some point during the day, we'd get up with the attending and go round, see all our catheters, see our inpatients, and then just continually do nerve blocks. As the fellow, it was nice because I was in a supervising role of the residents, but also had an attending who is helping teach me how to supervise. Because I think the hardest part about regional anesthesia when it comes to teaching is just kind of learning how to teach someone a physical and tactile skill while not actually touching the probe yourself. And so our attendings were great in kind of teaching me up to be able to teach the residents. And so at our university, that would go until about 2:30 or 3 p.m. and then I was off every day. I didn't take any call, didn't have any late stays as a fellow, and so that was awesome. It was a very nice schedule as a fellow, that's for sure.
Nice. So, you mentioned that MUSC is a non-ACGME accredited
Mhm.
fellowship. So, with the ACGME accredited fellowships, are you not able to have that mixture of being and attending some of the weeks and not and attending some of the weeks?
So it's dependent on the fellowship. Now, MUSC is actually ACGME accredited moving forward. So our current fellow is the last one. So moving forward, we are ACGME accredited. That means that it will be a 100% fellow time period. So you would be hired on fully as a fellow, not the half and half. With that being said, while it hasn't started yet, some things in the works are moonlighting as attendings. So we do late stay days. And the talk has been that those opportunities would be available for the fellows if you wanted to stay after your normal 3 p.m. fellowship ended and pick up some hours with extra pay as an attending. And then also weekends, basically picking up call shifts on the weekends as an attending would probably be an option as well. And so I think most places with ACGME accreditations do that option because again, once you finish residency, you're able to work as an attending, and it's just independent of the organization and where you're going, kind of how much they allow.
I see. And then for education, did you guys have didactic days or did you have breakout sessions each day for education during your fellowship?
So during fellowship, we did not. So we had recorded lectures. So we had 3 to 4 recorded lectures each month, and so it was a little bit self-driven study. And so on our fellow days, if there is downtime, we'd be expected to kind of do some of that education ourselves on pre-recorded lectures from our anesthesia faculty. And so we had a really good lecture series. Like I said, at least 2 up to 4 every month set out on different regional topics for us to go over and then review with our faculty members as questions arose. And then just in-person training, kind of on the job, hands-on. Anytime we had rare or specific nerve blocks or very difficult cases, we'd take over the probe, the attending would teach us. And so I feel like it was a good experience.
Nice. And I know you mentioned earlier that you guys do a lot of blocks. It's a very robust regional program that you guys have at MUSC. Can you kind of give a summary of the type of procedures that you guys do?
Yeah, for sure. So we're a little bit different from a lot of other institutes. So our most common block is actually a QL block. A lot of places are doing TAP blocks. We have kind of steered away from that and started doing a lot of QL blocks. So I would say most days at our main hospital, we have between 8 to 10 QLs that we do. We do it for every open abdominal case. Even a lot of laparoscopic cases, our surgeons have come to us and been like, even in laparoscopic cases, it's a night and day difference in their pain impact you for their patients. And so we've started having us block every belly case, which can be a lot. That's why we have a lot of blocks. But outside of that, we do a lot of upper extremity blocks and a lot of lower extremity blocks. So hips and knees, obviously huge. We do a pretty robust orthopedic surgery and joint replacement team. And so we're doing a lot of paying blocks, AC blocks, and then we have a big foot and ankle service. So a lot of ACs and pops for that. In our ambulatory centers, we're doing shoulders. So as third-year residents, as CA2s, our residents are going out to our ambulatory center and doing probably 10 to 12 interscaling catheters a week for shoulder replacements and shoulder scopes and rotator cuffs. So a lot of bread and butter blocks. We also, our department put out a big study on some superficial cervical, or no, sorry, some stellate ganglion blocks, excuse me. And we're doing probably 7 or 8 a year stellate ganglion blocks for people in intractable VTs. They put out a good paper on it. And so that's kind of fun. Getting called to true emergency situations where you can kind of stop a code with a nerve block is pretty cool and somewhat rare. And so we get a handful of those a year, which everyone gets pretty excited about. Obviously, if those come up, the fellows always get the first call from the attending to come hang out and kind of see what that is. So a little bit of everything, a lot of QLs, a lot of lower extremity, but we get a good variety.
Yeah. No, yeah, that sounds very robust. I'm at Henry Ford and we do a lot of tap blocks rather than QLs, but we've also been starting to do some stellate ganglion blocks on my last regional rotation for VT storms.
Yeah, it's definitely it's the only true regional emergency. We think of regional as somewhat of an elective thing. It helps with pain, but when you get in there and can stop someone from being in VT and kind of give the team a 7 to 10 day period to regroup and figure out a plan, it can be pretty impressive. And so we've started to do, like I said, a handful. Our cardiology service and our CT surgery service and the CVICU at MUSC know like once they get down step 1 or step 2 of that pathway, they're calling us to come get those blocks in so that they can kind of come up with a better plan and work with the EP folks to kind of figure out if there's ablations or what else to do. So it's definitely a cool thing to be a part of.
Nice. And I know that you went to residency and then fellowship, and now you're an attending at MUSC, but for yourself or for other fellows, what did the job search look like when you were looking for jobs? Were you only shopping at MUSC, or did you kind of look around at other centers nearby?
Yeah, so I looked at some private practice jobs in the Charleston area and a few hours outside. Obviously, these days the anesthesia market's pretty good, and so there's lots of markets where you can go, you can make a decent amount of money. Calls not as bad as it used to be, things like that. But honestly, for me, I always knew I wanted to stay at MUSC if there was a job opportunity. Charleston's a pretty highly coveted place to live, and so our faculty's been pretty full since I started residency 5 years ago. And thankfully, there was some growth and some need for more people around the time that I was looking. So I was very, very thankful to be able to stay on afterwards. But yeah, I did look around. I think having a regional fellowship was pretty highly coveted by a lot of places because the growing field of anesthesiologists in practice are getting a fair amount older. A lot of them are in their 60s. They didn't train with ultrasound. They're starting to use it. But they're not as robust at blocks as a lot of the people graduating now. They didn't have the programs where we are getting this many blocks. And so a lot of my colleagues that didn't even do regional fellowships go in and they're immediately the most experienced regional provider. So having that extra year of training, a lot of places were very interested in that, even asking me to start like an acute pain service for the hospital inpatient just coming out. And so I think it's an important thing that a lot of people are looking at and valuing. So I think that was pretty cool. But yeah, I always knew I wanted to stay in academics, at least for the start.
Nice. And then while you were in fellowship, do you feel like you had a good amount of time to study for your boards, during your fellowship year?
Yeah, so I think that was one of the best parts about my fellow weeks is because we were done at 3 every day. I mean, I had a ton of time to make sure that I was staying on top of things. For advanced, obviously, it happened in July of my fellow year, so it was right at the very start. So it's not like I had a ton of time just because of when it was. But on my fellow weeks, I still had plenty of time. When it came to oral boards and things like that, so MUSC has a really good mock oral program for the residents and they include all their fellows in that. And so twice a year, they set up for every person from CA1 on to do a full mock oral exam with some of our attendings who are examiners. And so when they would set that up, the fellows would be included in that. And so I did it, I guess, 6 times as a resident and then an additional 2 times as a fellow, a full hour and a half mock oral, exactly how it is at the real site with people who are actual examiners at the real site and feedback afterwards and things like that. So I think that was super helpful, not only at the time, but that they included us with the residents and kind of that preparation. I think it was really important. Made me feel a lot more confident going in that, I had sat down, I had done it with people who actually do it and gotten feedback and things to work on and how to prepare the best for it.
Nice. And what would you say is, if it already hasn't been mentioned, your greatest strength or favorite part about your fellowship program?
I think just the amount of exposure we have. So again, the fact that there's so many blocks that we do, you're definitely after like 2 or 3 months, you feel like you can totally go on your own, do all these blocks, and then you just have an additional 9 months of just really training, getting to see the obscure, getting to learn how to teach, especially for people that are interested in academics like myself. Like I said, that's honestly the hardest part about regional in the academic setting. It's not knowing what block to do. It's not knowing how to do the block yourself. It's learning how to teach someone who's maybe only used the ultrasound a few times, how to find a picture, see their needle, be safe, and get a good block done. And so I think just all that repetition doesn't do anything except strengthen your skills as a teacher and as a regional anesthesiologist. So just the vast numbers we do obviously is a huge thing. And then I'm a little biased because I've only ever been there, but I love the people at MUSC. It's one of the reasons why I stayed. I think we have wonderful attendings who have all sorts of interests from research to finding new blocks to kind of being on that ASRA team of people who are kind of doing cutting edge things. And so I think that the team at MUSC is awesome and I enjoy working with them.
And on the flip side, is there anything that you wish you could improve from your fellowship year?
Yeah, I think the one of the things that we saw as a weakness, which is why we've converted to the ACGME accredited side of things, was because we were half fellows, half attendings. We didn't have the full time. So a lot of things we talked about earlier about like protected research time and didactics and things like that. Part of the reason why it was self-guided is because we just didn't have time. So we were using our 2 weeks a month really with hands-on stuff. and then taking time as an attending when we're on those weeks when we have downtime to kind of do our lectures. And so with the new ACGME accreditation, I think there's going to be a lot more dedicated to didactics as well as getting protected time for things like research. So as an ACGME accredited program, you have to have blocks just like residents do, where you get your block schedule. As a non-ACGME, we did not have blocks. It was like these 2 weeks, you're just going to do blocks. These 2 weeks, you're going to be an attending. That's how it is. Now they'll have a month just truly for research if you're interested. They'll have electives. You can go to certain hospitals to do certain things. And so that makes it to where you can kind of tailor your experience more than just these 2 weeks you're going to go block where we need you. So I think the weaknesses have been addressed, which is good. It's going to kind of provide a great little program moving forward.
Awesome. And then finally, do you have any recommendations or advice that you wish you could give yourself as a resident or a med student that's trying to start their journey in regional anesthesia?
Yeah, I mean, just try and soak in as much as possible, not only in regional, just in every field of anesthesia for the residents. Even if you don't think you're interested in it. From the start, I thought I wanted to do cardiac anesthesia as a CA1. That's where I was going to do. And my fellowship director and one of my mentors was our regional fellowship director. And she told me early on, she's like, "Are you sure you don't want to do this? Like, I think you'd be really good at it. You might enjoy it." And I was like, "No, no, I don't think I'm really into it." Until I did my first regional rotation and kind of fell in love with the ultrasound and the skills required for it. And so I would say just be open to everything. Even if you're going in thinking you want to do one thing, don't pigeonhole yourself. Learn about as much as you can because in the end, even if you don't do a fellowship in a certain thing, you might find yourself in situations where you need those skills that you learn in those different fields to move forward. As for medical students, again, the same thing. Just be open to learn as much as possible. I don't think I had any idea what I wanted to do as a medical student when it came to anesthesia subspecialties. I think deciding I wanted to do anesthesia was a big enough decision for me. And so just keeping an open mind to everything. Things you can learn on all your rotations can transfer through all specialties. So whether you're on a surgery rotation as a medical student, even if you don't have any interest in doing it, things you learn can help you as an anesthesiologist, just kind of knowing what the other fields are doing. So I think just keeping an open mind, trying to absorb as much as you can while you're learning, because one day you're going to be on your own, you're going to be the supervisor, and you're going to want to have as much information as possible to make those important decisions. So just keeping an open mind to everything.
Great. Well, I think those are all the questions I had for our interview today. So I think we'll conclude our interview with Dr. Moore, recent regional fellowship graduate from MUSC. Thank
Yeah,
you.
thank you so much, Chi Chi. Appreciate it.